So the first description of CDH was done in 1752 in a baby who had a right-sided CDH, but unfortunately the baby died, and this is the autopsy of the baby. The first repair of CDH was done, I think it was in 1920 or so. That was in a 9-year-old baby, or a 9-year-old child, and the first neonatal was done is about 1925, I think, or 1930. That's a bit of history. When you go to epidemiology, 1 to 4 patients in 10,000 live births worldwide. This is the prevalence of CDH. But there's something called hidden mortality for those patients, where there's about a third of these CDH patients are actually stillborn, and there's about 50% elective termination and all CDH babies. So we think that probably the prevalence is much higher than that. Because of these reasons. So risk factors includes advanced maternal age, maternal pregestational diabetes, alcohol and tobacco use during pregnancy. The majority of CDH cases are sporadic. However, there are few reported familial cases. If there is one affected child in the family, the chance of having another baby is about 2%. Associated aneuploidy like trisomy 21, 13, and 18 are fairly common. 80% of the CDH is in the left side. With regards to the embryology of CDH, again, it's not fully understood. It is a process that starts at 4 weeks of gestation. The diaphragm develops from 4 main components, being septum transversum, pleuroperitoneal fold, esophageal mesentery, and abdominal wall or body wall mesoderm. Now, why does CDH develop? Again, it's not fully understood, but the thinking is that there is an incomplete development of the pleuroperitoneal folds posterior-laterally, as well as failure of muscularization of the diaphragm prior to closing of the pleuroperitoneal canals. This is a diagram just shows you from the left side of the 5th week gestation, green being septum transversum, 2 is pleuroperitoneal, blue is 2 pleuroperitoneal folds, number 3 or red is peripheral body wall mesoderm, and number 4 is mesentery of the esophagus. So they kind of grow and develop and then join in the middle and fuse to form the diaphragm. The septum transversum is thought to form the central tendon of the diaphragm, while the pleuroperitoneal membranes and the body wall mesoderm forms the muscular part of the diaphragm. Another thing that actually can happen with CDH is, importantly, is pulmonary hypoplasia. And the question is, why does that happen? There are theories that try to explain that the pulmonary hypoplasia is probably related to the herniating viscera that causes pressure that impedes the lung development. And that one's the classic and kind of a long-lasting acceptable theories. But another theory talks about a common effector, which means that basically there's an insult that happened that resulted in both lung hypodevelopment and CDH as well of the diaphragm. So they're not caused by each other, but rather they're caused by a common insult. So what is pulmonary hypoplasia? It is a process where you have an underdeveloped airways. You have a decrease of the bronchiolar cross-sectional area. You have a decreased radial alveolar counts. You have decreased alveolar volume. You have thickened alveolar membranes, and you have increased interstitial tissue space. Now, the degree of pulmonary hypoplasia is variable among CDH patients, and unfortunately, we don't know the reason why that happens. In addition to pulmonary hypoplasia, pulmonary hypertension is also a significant entity for CDH patients. The feature of that is there is a decreased overall pulmonary vasculature in the lungs. There's prominent vascular remodeling, being hypertrophied muscularized wall with a very thickened media and adventitia. There is also, in addition to the structural changes of the vessels, there's also increasing overreactivity of the vessels, being exaggerated contractions and impaired relaxation. Also, the peripheral pulmonary vascular resistance is increased as a consequence of all of that. So what happens when you have a high pulmonary vascular resistance? You basically started to have right to left shunting via the PDA, via PFOs, and then you end up with hypoxia. Now we know that hypoxia tends to cause pulmonary hypertensive crisis, and then you go through that vicious cycle again and again. That's why those patients tend to get very sick in the few days of life. So in addition to pulmonary hypoplasia and pulmonary hypertension, there's also cardiac dysfunction that can happen to patients with CDH. 18% of those patients have cardiac defects. The minority of them have major defects. But those who have no anatomic defects, 40% of CDH patients, they have actually cardiac dysfunction. That cardiac dysfunction could be isolated left, isolated right, or it could be biventricular. Now, we know now that if a baby has CDH with left ventricular dysfunction, this is associated with significant mortality and requirement for ECMO. This is basically a graph that shows you, so the top line basically shows you a CDH baby survival that are normal, so normal cardiac function. The line just behind that, the dotted line, shows you the babies who has right ventricular dysfunction only. So you see the survival is not that much different. But if the one after that, which is kind of the dashed line, is a baby where they have left ventricular dysfunction. You see there's a big difference in survival. And the last one is basically biventricular dysfunction. So if you have ventricular dysfunction in addition to CDH, then the survival changes significantly. Classification based on the size of a defect, you have Bochdalek in the posterior lateral region, or you have Morgagni in the retrosternal region. We'll be focusing on Bochdalek for the remaining part of the discussion. So what about Bochdalek? Can we classify the defect size based on the size? The answer is yes. We have 4 classification, A, B, C, and D, and A being a very small defect. You can see a very small defect, about more than 90% of the diaphragm is present. B, you have only 50 to 75% of the diaphragm is present. C, you have less than 50% of diaphragm is present, and D, you basically have less than 10 or complete agenesis of the hemidiaphragm. And now, I think for all of us, it is important to try to document that when we operate on those babies and try to kind of look at the diaphragm and try to see, am I dealing with A, B, C, or D? Because the higher the classification, the worse the prognosis for those patients. And that's been found in several studies. So let's go prenatally. Most of these patients are actually diagnosed prenatally on prenatal ultrasound, usually at about 22 to 32 weeks gestation. Unfortunately, ultrasound is operator dependent, so it may not pick that up early on, but it's usually visible on ultrasound. MRI, again, is not routine. It is reserved for uncertain cases or cases with moderate to severe risk factors in order to better inform the family. Optimal time for MRI is anywhere between 24 to 28 weeks gestation. Most frequent sign that is seen on prenatal ultrasound is absent abdominal gastric bubble or a presence of intrathoracic stomach. Other things that can be seen is liver in the chest or the presence of polyhydramnios. Other risk factors that you look for when you have a prenatal ultrasound is a lung to head ratio. So what is lung to head ratio? It is basically looking at the contralateral lung, so not the ipsilateral lung, but the contralateral lung, and calculating its area. And that is at the level where you can see the 4 chambers of the heart. Okay, so you go at the heart, look at the 4 chambers, and then look at the adjacent contralateral lung, and then measure the area. And there's various ways to measure the areas. Commonly is the tracing or tracer technique, which seems to be best. Now, LHR that is, and then you basically control that to the head, so it's a lung to head ratio. Now, LHR that is less than 1. Usually indicates a poor prognosis, particularly if you look at the very, very late gestations. Because we know that LHR tends to improve as the fetus is growing. LHR more than 1.5 actually carries a very favorable prognosis. But however, the problem with the LHR is the LHR number is not controlled for gestational age. So if you want to control it for gestational age, then you do observed over expected LHR for gestational age. Again, and to make it easy for you, if you look at left CDH, then the observed or expected LHR is less than 25%. So less than 25% is bad. Okay, if you look at left CDH, right CDH tend to be different. They tend to have worse outcomes, at least for the majority of the studies. This has been challenged lately. But right CDH, less than 45% of observed over expected LHR carries a significant mortality. If you want in details, then you look at, for example, less than 15% LHR, then the survival is less than 1%. 15 to 25% is about 20%. Greater than 45% is usually greater than 75% survival. So this is a good kind of to keep it in your desk for reminding. What about other parameters that can be used in prenatal ultrasound? Fetal lung volume is also commonly used, which basically calculates the volume of both lungs. And it was actually correlated with LHR and survival. Again, if you have fetal lung volume less than 25%, then the chance of survival is about 20%. Greater than 35%, you have 80 to 90% survival. What about the liver position? Now, it has been found that if the liver is up, then the survival is about 45%. While the liver is down, great survival over 95%. And that can be seen with ultrasound, but again, MRI seems to be much more accurate in looking at the liver. Okay, so what other things you ask for if you have a prenatally diagnosed CDH? So it's important to look at the heart, so you do a fetal echo, because that is important to stratify patients. The presence of cardiac anomalies put the babies at a high risk of mortality by about 60%, especially if the cardiac anomalies are major anomalies. Please also recommend amniocentesis and look at karyotyping, look for trisomies. So in a nutshell, factors that are associated with poor survival in CDH patients are prematurity, major cardiac anomalies, cardiac dysfunction, LHR less than 1, observed over expected less than 25, liver up or stomach up. Stomach up has been kind of debated, but generally the top 5 are the main ones. So what about delivery planning? In a nutshell, looking at all the available evidence, there's no benefit of C-section and CDH. You leave C-section for other indication, but not for CDH. The best is scheduled for term delivery. Now, premature delivery is bad, okay? And no elective delivery before 38 weeks. If you look at this graph, which shows you the gestation age and survival, this is more than 37, and this is less than 28 weeks. If you go down, if you go backward, the survival drops significantly. So prematurity is bad for babies with CDH. Therefore, it's not recommended to deliver them prematurely. You want to make sure that they deliver in a liver 3 NICU center with pediatric surgeon available. For those who have high risk features on prenatal ultrasound, you probably want to make sure that they go to an ECMO center as well. So what is the presentation? Presentation, usually they're diagnosed prenatally, and they go to NICU, they're watched. Usually they do well in the first kind of 6 to 12 hours, and then they start having respiratory distress. With the varying degrees. They start to get into tachypneic, get retractions, gasping, and it could be cyanotic. When you examine them, you probably find deviated trachea, borborygmus as well in the ipsilateral chest, which is basically hearing vowel sounds. You look at the scaphoid abdomen. Sometimes they can have actually delayed presentation, particularly for small defects, like in the first few years of life. Associated anomalies commonly are, you have cardiac anomalies in about 20% of cases, mainly VSDs, ASDs. You can have renal anomalies as well, about 5%. Neurologic anomalies, about 5%. Other not significant anomalies as well. But trisomy 18 is the most common chromosomal anomaly for CDH patients. And as you know, trisomy 18 is not compatible with life, so that deserves special discussing about not to operate in those babies. So how do you manage them? So keys in management of CDH patient is, this is a disease that is very complex. You need a multidisciplinary team to manage these patients. So it is not a routine case. It should be managed by a team. This team should include a good neonatologist. It includes a pediatric surgeon. It should include a pediatric cardiologist. It should include a pediatric anesthetist and ECMO team if available as well. So all these people has to sit down, evaluate these patients every day and make decisions, because those patients, they can be very good, they can be very, very bad. So you want to know, you want to get all the minds together, you want to discuss this in a multidisciplinary fashion with a meeting at least once or twice per day. Early intubation is important, so do not wait for those babies. Once they start getting some distress, then go ahead and intubate them early on. Avoid back mask ventilation because it doesn't do any good and it causes barotrauma and it may cause pneumothorax. Get your intravenous access. Now, I see commonly that people try to use umbilical lines. It is not good, particularly UV line, because of the anatomy of the liver. The liver is usually central. The UVC usually goes to the left side. And there's also chances where you injure the vein or you get intraperitoneal injections of fluids. So avoid UV lines. You can use UA line if you need it, but most importantly, get a PICC line because that's what you need for those babies. You want to make sure you monitor preductal and postductal O2 sats and look for the difference because it can point you toward any pulmonary hypertension episodes. You have to put an nasogastric tube and decompress the bowel. That helps with oxygenation. Get a chest X-ray and get frequent ABGs. These are X-rays of baby with CDH. On the left, you see a left-sided CDH. You see bowel in the chest. You see the NG tube coiled in the chest, indicating a stomach in the chest. You see deviated mediastinum, deviated trachea. You can barely see the right lung. On the other X-ray, this is a right-sided CDH. You can't see the diaphragm, bowel in the chest, NG tube deviated, and mediastinum, and so forth. So back to management. So it is important to get an echo within 4 to 12 hours of life. The reason to do an echo is to look for any structural cardiac defects. You look at signs of pulmonary hypertension, and these are usually suprasystemic right ventricular pressure. You look at tricuspid regurgitation, you look at right ventricular enlargement, and you look at septal bowing. And these are secondary signs that can tell you that there is a significant pulmonary hypertension here. You also evaluate cardiac function. And also another benefit of echo is that you can actually monitor the response when you give a medication for pulmonary hypertension. And commonly we give inhaled nitric oxide, and then you can use the echo to actually monitor the response. Also, echo is important if you have sudden deterioration of a baby. Let's say all of a sudden the baby is severely hypoxic or severely hypotensive, then you need an echo to reassess the situation. But in general, you need a minimum of 2 echoes, one within the first 48 hours and another one later in about 2 to 3 weeks into life. You want to give gentle sedation. You want to give analgesia as well. You want to avoid to deeply sedate those babies. You want to avoid to paralyze them because that interferes with the pulmonary dynamics, with the respiratory mechanics. That also increases the tissue edema as well and make the lung wet. It makes the bowel wet as well, and that can make things much more complicated. You want to give them fluid. You want to monitor the glucose. You want to control the temperature. You want a minimal handling, so you don't want a lot of stress on this baby because stress can provoke pulmonary hypertension. You also want to get a brain ultrasound if you're discussing ECMO, particularly in the premature babies. So what about ventilation? What is the key to ventilate these babies? What are the principles? So generally the principles are pressure-limited ventilation to avoid barotrauma and allow permissive hypercapnia. Okay, so your initial settings are intermittent mandatory ventilation or IMV. Your PEP to begin with is 18 to 22. Your respiratory rate 30 to 50. You get a PEEP of 5, tidal volume 3 to 5 ml per kilo, and FiO2 of 100%. You can start at 100%, but you start coming down as soon as you can in order to avoid the tissue injury because of the oxygen-free radicals. So you don't want to keep those babies on 100% FiO2 if you can lower it down. So what are the targets? What are your targets to adjust ventilation? You want a preductal SAT of 85 to 95. You do not want a 100% preductal SAT. That is too much. You want to lower that down. You want a PCO2 that is 45 to 60, so allowing a little bit of a permissive hypercapnia. You want a little bit of an acidotic side, so 7.25 to 7.4. You do not want to increase the PIP more than 25 because otherwise you get barotrauma. You do not want to increase the PEEP above 10 to 12. So that's really, really important. If you cannot achieve those targets by your settings, then you have to move to a different ventilation strategy. And we'll talk about that in a minute. You want to repeat a blood gas probably every 1 to 4 hours. And you want to get a daily chest x-ray plus x-rays whenever there is a sudden situation change. Like, for example, a baby all of a sudden is hypoxic. You want to make sure they don't have pneumothorax. So you want to get a chest x-ray. Other ventilation strategies that are reserved for high-risk patients or patients who cannot achieve the targets that we talked about. For example, somebody who is very acidotic, so this PCO2, hypercapnic PCO2 is 70, 75, and you are maximum on your pressure support ventilation. Then at that time, you move to another strategy like high frequency oscillatory ventilation or even high frequency jet ventilation. So patients who are preductal sat less than 85, so you're at FiO2 100%, preductal is still less than 85%. Then you say this is enough. Now we move to high frequency. Or patient with CO2 is more than 70. Patient with pH less than 7.2. Patient, you reach your PIP more than 25, or your PEEP is over 5 to 10. So you connect this high frequency oscillatory ventilation. It shows your map between 13 to 14, amplitude 30 to 50, and frequency about 8 to 15. And then you need the neonatologist obviously to kind of handle that. High frequency jet ventilation also another option, and it is reserved for rescue mode. What about management of hemodynamics in babies with CDH? Your target map should be between 40 and 50 in a term baby. You want to monitor tissue perfusion. You want to make sure the cap refill is less than 3 seconds. Your urine output more than 1 ml per kilo per hour. You want to make sure the lactate is below 3. What if they're hypotensive? What do you do? Then you fluid challenge them. You give them normal saline 10 to 20 ml per kilo. You may decide to give them dopamine. You do not want to give them over much fluid, so you give them dopamine. Maybe you may need epi as well. Meldonone is a good drug that is used for a patient who has pulmonary hypertension and left ventricular dysfunction. That's a good drug that has inotropic effect, and it drops the pulmonary vascular resistance. Sometimes you need steroids. If you have somebody with refractory hypotension, probably related to adrenal suppression, so you give them steroids, sometimes they improve. And remember to use echo when you have refractory hypotension. With regard to blood transfusion, the hematocrit should be kept between 35 to 40%. What about inhaled nitric oxide? Now, it is used to mediate pulmonary smooth muscle relaxation, so it improves pulmonary hypertension. The indication of INO, again, is not very well defined, but generally it's a suprasystemic pulmonary hypertension. So when we mean suprasystemic, that means the pulmonary pressure is greater than the systemic pressure. Okay, and that and the echocardiographer or the cardiologist can tell you that, and as well as the preductal and postductal difference. If you have a difference that is more than 10 to 20%, that indicates the presence of pulmonary hypertension. At that time, INO is probably indicated. Dose is usually 10 to 20 is a starting dose. The concerns with INO is it's very expensive, and it is resource intensive, meaning you have to have a blender and you have to kind of deliver to its own special device. So what is the recommendation with regard to the use of INO is it is better to assess its response with echo. So let's say somebody was struggling with pulmonary hypertension, you put the INO on, and then you assess after a few hours with echo if there is improvement. If there's improvement, you continue. If there's no improvement, then you stop, okay? Just because it's a very expensive drug. The other problem with INO is that you can't take it to the operating room because it has to be, it cannot be connected through the anesthesia machines. It has to be separate. So you can't actually do it in the OR. Again, back to sedation analgesia, you want to give sedation. Options are midaz or fentanyl or morphine. You want to avoid deeply sedating those babies, and you want to avoid paralyzing them. What about surfactant? There's no benefit to support surfactant. What about prostaglandin E1 to keep the ductus open? This is a good drug if you need it. It is important for patients with suprasystemic pulmonary hypertension with signs of right ventricular failure, because you want to keep that duct open to vent the pulmonary pressure. And also you need it for patients with ductus-dependent cardiac anomalies. Another adjunct to treat pulmonary hypertension is INO, as we said. Milrinone is a good drug. Sildenafil is also a good drug for pulmonary hypertension. Other prostanoids and bosentan, they don't really have any clear benefit as far as literature is concerned. Prostacyclin also is a good drug for pulmonary hypertension. So what about unsalvageable CDH patients? What I mean by that is the patients that you see, they're very, very bad. They have significant pulmonary hypertension or maybe cardiac dysfunction as well, which you don't think you can actually operate because you don't think they will survive. So the percentage of those patients are about 10 to 20%, and usually because of a bad cardiopulmonary disease. Now, this has improved significantly because now we have different ventilation strategies. Now we have a lot of pulmonary hypertension drugs. Now we have ECMO as well. So that numbers is coming down. How to choose those patients? There are a lot of scoring systems out there. I just kind of summarized them here in the table that can help you understand what the mortality risk for those patients. Now, can you depend on those scoring systems? You probably can use them as a tool, but you cannot depend on them to decide to stop treatment. It is very important. These are good for mainly for research purposes and for kind of a resource utilization, but you cannot really use them for individual patients. You can use them to make discussion with families, but don't depend on them mainly to decide treatment. There are certain anomalies where you know they're not going to survive, like trisomy 13 or 18, and then you can here make a decision not to operate in them when you discuss with families and with the treating neonatologist. But as a nutshell, you want to make sure that you keep the non-repair to a very, very, very minimum. You're going to try to fix everybody as much as you can, okay? What about ECMO? So ECMO is a life-sustaining option for patients who cannot be saved with high-frequency ventilation, high-frequency jet ventilation. They're doing bad. They have significant pulmonary hypoplasia. They have significant pulmonary hypertension. They probably have cardiac dysfunction as well. So they're not. It doesn't look like they will survive. So ECMO is a good option. The benefit of ECMO to save those babies is very controversial, okay? Because it is hard to study this group of patients. Obviously, it's hard to randomize. So again, you can't really you don't have figures to address what's actually true mortality benefit for those patients. But again, it's a good tool to give the patients who is basically dying. Okay, so try to do that if it's available in your place. Throughout all CDH patients in the US, about 30% of them go on ECMO. Now, options of ECMOs are either VV or VA. And I'm not going to go into details to explain both because it's a big topic, but whether you choose VA or VA for CDH patients, there's no clear benefit of survival benefit. Some centers use routinely VV, some centers use routinely VA. The main difference is that VA gives you support to the cardiac function, gives you supportive pressure, while VV is basically just support ventilation and oxygenation. The risk of VA is mainly neurological complications. The risk of VV is mainly renal complications. The average duration on ECMO run is about 1 to 4 weeks. This is numbers from the US. So what are the indications of ECMO? Indications of ECMO, generally patients who are not doing so well. So let's say preductal SAT less than 85%. A patient who is persistently acidotic. So you give oxygen and the acidosis does not improve, the lactate is high, they're just not doing well. Patients who are severely hypercapnic, so over 70 despite your maximum ventilation strategies. Patients who are hypotensive, resistant to fluid and inotropic support. Those patients will be served better by VA because VA supports the blood pressure. Oxygenation index is very good, and I recommend all of you to calculate oxygenation index for all of your CDH patients. It's a good exercise and keeps you understanding how bad or how well this patient is doing. But oxygenation index that is more than 25 basically is an indication to consider ECMO. Persistent high ventilatory settings, and we spoke about that. What are the contraindications to do ECMO? Significant congenital anomalies that we said, for example, very bad cardiac defect and so forth. Lethal chromosomal anomalies like trisomy 18, trisomy 13, intraventricular hemorrhage more than grade 2, or weight less than 2, or gestation age less than 35. However, I underline those because there are centers who actually do ECMO for smaller than 2 kilos or smaller than 34. So it's not a true contraindication. Okay, now surgical repair. When to fix this? So let's talk about patients who is not on ECMO, so just your usual patients. In the past, those patients were fixed immediately after birth because it was thought that if you fix them early, they will breathe better, their lungs will improve, their lung will grow, and they will do better. Unfortunately, those patients who were treated very early, when I say early, I mean first day of life. Those patients who are fixed early, they tend to have very high mortality. So then a new trend came about, which is basically, let's wait for those babies to see if they improve. And all of a sudden we get improved survival, okay? So then there's a lot of studies to look at what is the benefit and what is it actually we can recommend a specific time to do this. There's a lot of retrospective, low quality evidence to suggest waiting a little bit for a few days is better. But if you look at good quality studies, so there's a Cochrane review in 2000 that looked at 2 good quality randomized control trial comparing early repair less than 24 hours versus late repair. And there's no significant difference in survival or length of stay. However, there was a little bit of a trend toward mortality in early repair group. So in a nutshell, optimal time remains unknown. Most of the centers will repair between day 2 to day 5 of life. And the idea of to do that is basically you want to allow the baby to transition from the fetal circulation to the adult normal circulation, and to optimize you want the cardiac function to kind of reach a good balance. You want the pulmonary status to kind of equilibrate, and then you want to operate in them. And then and usually they're very good in the first 24. So the first 12 to 24 hours, this is what we call a honeymoon period, where the babies actually look very good because they're still kind of transitioning into the normal circulation from fetal one. But then after 24 hours, you start seeing pulmonary hypertension. You start to see them doing not so well. So you want to wait a little bit until they go over that transition period. So what about patients in ECMO? That's a big debate, whether you operate, if you have a patient who's not doing well, you put him on ECMO, and then what is the best? Is it to operate on ECMO, or to wait until they go off ECMO or get decannulated and then you operate after that? The problems of operating on ECMO is there is a risk of bleeding because those patients are anticoagulated. So there's a very significant risk of bleeding. It is technically difficult because the tissue are edematous, the organs are edematous, so it is challenging to some extent. There is potential benefit, which is to restore the anatomy that may help, they may help them coming off ECMO. So in general, the centers who actually advocate for repairing on ECMO, they do it within 72 hours, and their numbers are reasonably well. Now, if you look at those who do after ECMO, the advantages are that the babies is off ECMO, so the anticoagulation is off, the technical challenges of ECMO surgery is not there. There's a decreased risk of bleeding. There's improved survival, and some studies that looked at comparison between early or off ECMO. The problem, though, is that you don't know if this patient will come off ECMO. If you say, well, this is a patient who's born now, he's doing badly, we put him on ECMO, and I decided to operate when ECMO is off. But you don't know. These patients may actually not come off ECMO. So there's a challenge there where you really cannot know. So you may end up not repairing those patients. They may die because you have decided to do it after ECMO. So there are 2 camps: early repair, early ECMO, or after ECMO. Again, the numbers are not different. So there's no conclusion. But in a nutshell, what I personally would conclude is that repair is on ECMO after ECMO is great if you think this baby will come off ECMO. If you think this baby is probably not going to come off ECMO, then early repair within 72 hours is better. So what about regular repair? When do you think the patients are considered ready for surgery? Now, there are a few factors. You look at the preductal SAT, it has to be between 85 to 95. Baby has to have normal blood pressure, pulmonary pressure that is less than systemic. FiO2 less than 50%, good urine output, and a normal lactate. If you have all these findings, then the baby is ready for surgery. What if those findings are not achieved and the baby remains sick? So then you have to decide. You do not want to let this baby go beyond 2 weeks without fixing. So you want to fix them early on. But the problem is that if you fix them, they're sick, their mortality risk is quite high. The other option is to palliate, which is to say, we're not going to treat, we're just going to see if this baby survives or not. So I think option A is probably best. You want to fix them early. You want to make sure that the family understand that we've waited, we've given this baby a chance, but the baby is not getting better, and we will have to just go ahead and operate. And there's a high chance of intraoperative mortality. About surgical technique. Now, technique includes either open, which is a laparotomy, or even thoracotomy, but mainly most people do laparotomy, or MIS, which is usually thoracoscopic repair. And then we will talk about that later. OR versus NICU, that is important, whether you operate in OR or NICU. Obviously, all of us wants to be in the OR. It's better for us. But sometimes it is risky to transfer this baby to the NICU, to the OR. So you want to have this discussion with the neonatologist. You want to have this discussion with the anesthesiologist. Sometimes baby are on high-frequency ventilation that cannot be easily moved. The baby could be, they're dependent on nitric oxide. They cannot disconnect it. So at the end of the day, you may end up operating in NICU for certain babies. What are the principles of surgery? Let's say you decided to do a laparotomy. So you do a left-sided laparotomy, transverse laparotomy. You reduce the bowel. Make sure you watch the spleen. It can bleed very easily. You excise the hernia sac if you find it, which is present in about 20% of patients. You want to make sure you dissect the posterior diaphragmatic leaflet. You unfold it. You assess the defect size and classify it A, B, C, or D. You want to repair then the diaphragm. Options of repair diaphragm, either primary, you approximate it together, either you put a patch or you get a tissue repair, and we'll talk about that. And then you close the abdomen, and watch out when you close the abdomen. You want to close the abdomen. If the baby has abdominal compartment syndrome, then you want to do something else, and we'll talk about the options. Chest tube is not required for all patients. So what about primary repair versus patch repair? Now, this is subjective assessment of the tension. If you think there's too much tension, then you put a patch. You do not want a tension repair. Tension repair is bad because it has a high risk of recurrence, and also it is a risk factor for abdominal compartment syndrome. So these are two problems. The tension usually in the lateral area where the diaphragm is deficient. So this is the area where you really be focusing on. So commonly I would grasp to Babcock and approximate the diaphragm edges together and assess. Repair usually with 2O Ethibond. You can use Bludget if you want. Use simple interrupted or mattress sutures. What about patch use? There is several patches used. I'll show you a table, but the most common use is PTFE Gore-Tex patch, which is a 1 millimeter thickness patch. It is non-absorbable. And the idea is to put it in a way that is floppy, tension-free, cone-shaped shape. So basically you want it to kind of bulge into the chest so it looks like a native diaphragm. The recurrence rate with mesh patch repair is about 5 to 40%, so it's quite high depending on what paper you look at. The reason of recurrence is, remember, the patch do not grow, so when they recur, they basically recur very laterally when the baby grows. What about biologic mesh? They're not good because they get absorbed, so they have a high recurrence rate. This is a table that summarizes the patch option. One is a non-absorbable synthetic patch. We talked about PTFE Gore-Tex. Then you have the absorbable ones. You have Alloderm, Surgisys, Spermacol, all types of fancy meshes. Again, they're not good alone because they're having a higher recurrence rate. You have autologous muscle flaps, which is what we call tissue repair, and it is either split abdominal muscle flap, latissimus dorsi, or serratus anterior. So when you go to tissue repair, again, same thing we talk about. The recurrence rate for tissue repairs are lower than patch. It's about 4 to 11%. There is a risk usually of chest wall deformities. However, that was not proven. Again, tissue repair is a good thing to learn or see once or twice to be able to kind of know what the technique is. It's a good adjunct. Some people actually like to do it instead of patch. So if they can't do primary repair, they will do tissue repair. This paper is a good paper that describes a split abdominal wall muscle flap and a nice details. What about abdominal compartment syndrome? We spoke about that when we talked about congenital abdominal wall defects, but how to prevent it? You basically want to give an optimal fluid balance of this baby. You want to make sure that the bleeding and tissue handling is minimal to avoid tissue edema. You want to make the operation time short. You want to avoid tension repair of the diaphragm. And you want a good communication with the anesthesiologist. So if you reach a point where the anesthesia will tell you the ventilatory pressure is not good, then you want to have to rethink about not closing this baby. Now, how do you improve the situation for the baby to be able to close or even not closing? So NG decompression sometimes helps because it decompresses the stomach and allows some space in the abdomen. Meconium evacuation from the colon can sometimes help to lower the abdominal pressure. But if you can't, then the options are to either mesh abdominal closure, so you put a kind of a big mesh. Even a big mesh, it does not prevent abdominal compartment syndrome, but it increases the abdominal space, so it gives you some room. Other temporary closure device is silo, so you put a silo on and you wait for the baby to improve and then close after. Or you close the skin only, so you give a baby ventral hernia and you close, or you put a vac after you put either Surgisys or biologic mesh. Okay, now nice quick questions. What about rotation and rotational anomalies? Do you do a LAD procedure for CDH or we don't do a LAD procedure for CDH? Now, rotational anomalies are common with CDH patients. However, there is no evidence to support routine LAD procedures. The chance of volvulus with those patients is very, very low. The problem with doing a LADS procedure is that you're doing more dissection, which is increasing the chance of postoperative bowel obstruction. If you're doing an appendectomy and you want to put a mesh, then basically you're in trouble because now you have a clean contaminated field. You may get a mesh infection. So in conclusion, no LADS procedure, no routine LADS procedure. What about reflux disease? We know that 30 to 70% of CDH patients, they have gastroesophageal reflux disease. And we know that about 50% of them may need anti-reflux surgery. However, I think this number is probably exaggerated. Again, recommendation, there's no evidence to support routine anti-reflux surgery. We cannot predict who are the patients who is going to improve without a surgery or not. So we leave it at them. If they end up having reflux in the future, it can be treated medically. If not, then we operate on them later on, but not at the time of CDH repair. What about sequestration? Less than 5% of CDH patients have sequestration, usually extra lobar. It can be found anywhere. It can be above the diaphragm, below the diaphragm. It can be even within the diaphragm itself. When you see it, please excise it. It's not a big deal. You avoid complications of sequestration such as infection or malignancy. Okay, now, good topic, thoracoscopic repair. Some people advocate for thoracoscopic repair for CDH patients, but I think you need to understand a little bit about the choice of patients. So who are the patients who are good for thoracoscopic repair? So basically hemodynamically stable patients, patient with minimal respiratory settings, or patient who comes late. The patients who are not good candidates for thoracoscopic repair are those who are hemodynamically unstable, those who are in ECMO, those who are significant cardiac anomalies, those who are small or having significant pulmonary hypertension. Now, what are the potential advantages of thoracoscopic repair and the potential disadvantages? Now, people who does this and like thoracoscopic repair, they think it's good because it enhances recovery. It has better cosmesis. However, I think the most important advantage of thoracoscopic repair is a decreased risk of postoperative bowel obstruction. On the other side, also shorter length of stay and possibly a lower risk for musculoskeletal abnormalities. What about the potential disadvantages? Now, the main criticism of thoracoscopic repair is the higher recurrence rate. If you look at multiple studies, kind of old and new, most of these studies shows increased recurrence rate after thoracoscopic repair. We know that there is a learning curve, so you have to do a certain number of cases before you're actually able to do it well. It is technically challenging, particularly if you're actually putting a patch and you're trying to sew thoracoscopically. Also, there's a risk of worsening hypercarbia because you're insufflating some CO2 in the chest, so CO2 may go a little bit up. However, that's usually a transient phenomenon. So in a nutshell, MIS versus open, evidence generally is very poor. Most comparative studies are retrospective, and you know the problem with retrospective is the selection bias. For example, those who does large volume of thoracoscopic repair, they tend to choose thoracoscopic repair for the patients who are good, who have small defects, who are big size, less degree pulmonary hypoplasia. So the results should be bad, should be good, because you're basically choosing the good patients. So be careful of selection bias. Some MIS advocates also convert to open if you need a patch repair. I think that's a reasonable approach. I would go, for example, into the chest with a thoracoscope, look at the diaphragm. If it's small, I'll close it thoracoscopically. If it's big and I need a patch, then I will do a laparotomy. Okay. If you want to look at this evidence, remember that the follow-up is variable. If you look at recurrence rate, for example, the question is, how do you catch up the recurrence? If you're doing routine X-rays, then you will know when your patient recurred, but most people don't do routine X-rays. So even if the patient recurred, if they're asymptomatic, you will not know. So the recurrence rate is actually still vague. This is a good paper that I recommend all of you to read. If you want to answer the question about diaphragmatic hernia MIS versus open, basically it's the debate between advocate of each technique. But in general, I highlighted here that the recurrence rate for MIS versus open, as you can see, the MIS is clearly as associated with a higher recurrence rate. This is also another systematic review and meta-analysis that included 3 randomized control trial. And basically they did pooling, and they showed that if you look at all studies, they favor open technique. This is looking at only recurrence. So recurrence is better or less with open repair. So in a nutshell, I think the keys, if you want to do a thoracoscopic repair, it's not wrong. I think you have to make sure that you are familiar with the technique. Make sure you're competent in the technique. Make sure you actually can suture intracorporeally without a problem. Make sure you're able to assess the tension thoracoscopically. Sometimes when we assess the tension thoracoscopically, we really underestimate the amount of tension compared to laparotomy. And also make sure that if you have big defects, just stop, do it open, do a laparotomy, and put a patch. I think these are if you want to improve, if you want to do MIS, you have to improve the numbers. We have to improve the numbers. We have to get the recurrence down. And this is the things that we have to do in order to get the recurrence down. Post-op complication could be early, like hemorrhage, early recurrence, could be moderate, like recurrence or infection, or could be late, like adhesive bowel obstruction or delayed failure. What about hernia recurrence? Now, this summarizes to you the hernia recurrence rate after each technique. So after open primary repair, about 3%. This is in the largest case series by the CDH study group, about 4,000 patients. Patch repair, 5 to 40%. Muscle flap, 4 to 11%. MIS repair, 8 to 40%. Again, factors depends on defect size, operative approach, technique, or the patch use. Most of the recurrence are asymptomatic. So what do we do with recurrence? Early recurrence should be repaired if it's within a few days or weeks. Late recurrence, if symptomatic, obviously need to be repaired. If asymptomatic, it's still debatable. Most people will repair late recurrence. However, if you have a small recurrence, you may choose watchful waiting after you discuss with the parents the options. But most people will fix all recurrences. What about bowel obstruction following CDH repair? It is not uncommon. It's about 10 to 15% of patients. Now, predictors: open repair has more risk of post-operative bowel obstruction. Patch repair has more risk. Liver apposition, more risk. And if you have done a LADS procedure, there's more risk of coming back with bowel obstruction. What about long-term mortality and morbidity? Chronic lung disease, about 50%. Pulmonary hypertension, gastrointestinal like failure to thrive, reflux disease, vertebral anomalies and thoracic anomalies, and some neurodevelopmental as well. So what about follow-up? It is important to have a multidisciplinary follow-up for these patients, that you do a long-term follow-up. These are the specialists who actually need to look at these patients regularly. It should be a risk-based follow-up, meaning that the patient who had a high risk should be followed much more closely. I generally would do 3 to 6 months for the first 2 years and then annual after 2 years. And they come with chest x-rays. This is a nice table that I'll leave you to read at home in the American Academy of Pediatrics, suggesting how do you follow CDH patients at certain times and what you should be asking for. I highly recommend you look at these two papers. These are clinical practice guidelines from the Canadian group and European group. They basically summarize the best evidence to manage CDH patients. I have incorporated most of the guidelines and recommendation in my presentation, but if you want more details, then you can go through them. What about diaphragmatic eventration? 2 slides to talk about that. It can be classified into congenital or acquired. Congenital is less common and it's not well understood. Acquired, usually it's post-cardiac or thoracic surgery or post-birth trauma causing injury to the brachial plexus. How they're presenting, usually they are asymptomatic. And sometimes they can progress to respiratory distress and respiratory failure. Now, this is an X-ray that shows elevated left hemidiaphragm in a patient with left diaphragmatic eventration. You can see the kind of a mediastinum shifted to the other side, and the trachea is deviated, and there's endotracheal tube. So you see a high riding hemidiaphragm. Sometimes it's difficult to know whether this is a CDH or eventration. So other dynamic studies that you can use to know is getting fluoroscopy. So basically the patient is breathing and you x-ray them, and you're looking for paradoxical movement. So when the normal diaphragm goes down, the eventrated diaphragm will go up, so paradoxical movement. Or you can look at the same thing using ultrasound as well. Basically you want a dynamic study. With regards to management, now indications of repair are respiratory symptoms or failure to wean from ventilator. Asymptomatic patients can be observed. Whether the options of repair is best via thoracoscopically, but laparotomy can be done, but thoracoscopic seems to be best. And the reason is that you want to be able to identify the muscle nicely. You want to be able to identify the phrenic nerve, which you can see through a thoracoscopy. Basically you identify the muscle and you plicate the diaphragm using 2O non-absorbable. And again, avoid injury to the phrenic nerve and the intra-abdominal organs. And I think we're done here and happy to take questions.
Thank you so much, Dr. Abdullah, for this perfect, brilliant, amazingly covered presentation for one of the difficult subjects in pediatric surgery. We have plenty of questions. I'll go through them. How to approach right-sided eventration, thoracic approach?
So right-sided eventration, it is very, very difficult to do a laparotomy to fix that. So I strongly recommend thoracoscopic approach.
Regarding recurrent CDH, is better to repair through the abdomen?
Recurrent CDH, okay, good question. Recurrent CDH, generally you have the options to either go through the abdomen or go through the chest. In general, you want to think about going into the field that you haven't operated on before. So if you have done the initial operation in the abdomen, you probably want to go through the chest into a virgin field. But again, it's not mandatory. You can choose to go through the abdomen. It is fine too. If you put a mesh, it will be difficult sometimes to get the mesh out from the chest. Generally, I will probably choose to either go the same technique or go to the other cavity.
Okay, great. If we found mecal diverticulum incidentally during the repair of CDH, can remove it?
Good question. So that's another topic, but again, incidental finding of mecal diverticulum, you do not remove them, okay? You're doing any other operation, appendectomy, bowel resection, whatever, you find the mecal, you leave the mecal, okay? There's plenty of evidence to suggest that the complication rate is much more than the benefit that you give for your patient.
Okay, great. Should we remove the sac?
So if you find the sac and you can easily remove it, you go ahead and remove it. The sac usually is present in about 20% of cases, so it's not that common. If the presence of a sac that has not been removed is probably a risk factor for recurrence. However, that has not been studied.
Can we use the usual Prolene mesh for repair?
Prolene mesh, I don't think it's a good mesh because it's quite rough mesh, so it may cause erosions to the bowel may get stuck to it. So the best mesh is a Gore-Tex mesh that has dual surface, so you leave the soft surface toward the bowel. And the PTFE the PTFE mesh in general is the most commonly used, and probably has the lowest recurrence among the other meshes that were looked at. But the Prolene mesh is not commonly used in the diaphragm.
Okay, great. Can repair be performed if baby is on high frequency ventilation or INO?
Oh yeah, you can, absolutely. The problem with repairing those patients is that you will probably end up doing it in the NICU because you cannot transfer the high frequency easily, or the INO. So you'll just have to accept doing it in the ICU.
Okay, thank you. Is there any indication for surgery in asymptomatic CDH found incidentally?
Okay, that's a very good question. I think there is no evidence to support either way. Most of us, if you see a CDH, we will fix it. The reason is that we are worried that the patients will end up having complications. Usually with CDH that are delayed presentation, you know that these patients usually have a small defects. That's why they did not present. And we worry that small defect with bowel inside is basically a hernia that can incarcerate anytime. And as you know, complications of hernia that incarcerates is far worse than complications of the operation when you do it electively before incarceration. So in general, most of us, we would fix delayed presentation of CDH. Right.
Okay, thank you. Do you advise for muscle relaxant post-op if there is tension repair?
Muscle relaxation. Which is he talking about CDH or what is he? Or which muscle relaxation you talk about?
He did not specify the muscle relaxant, but yes, I think he's speaking about CDH.
So I think he's probably talking about muscle relaxation in the abdomen. So do some sort of a mini component separation. I do not personally think that's a good idea. I think if you can't close and you think there's so much tension on the abdomen, it is safer to put a silo on or just close skin and let the baby go to NICU. Even if you close, if you release and you relax a little bit the abdomen, we know that abdominal compartment syndrome tends to develop a few hours later. So even if you're happy now, you say, well, now the tension is acceptable, you probably get a few millimeter extra. But once the bowel swell and all that, and after a few hours, you're probably going to come back for a decompression. So the best thing is to just, if there's a concern, put a silo or leave the abdomen open.
Okay, great. Do we use NGT as routine for all patients with CDH, or is MPO can be enough for a patient with a small CDH?
So preoperatively, give them all NG tubes. If you intubate them, that means they are sick. If you intubate them, that means there is significant pulmonary hypoplasia. To decompress the bowel is important to get some of the air out and improve their respiratory capacity. Yes.
Can we predict the timing of surgery by serial echo?
I don't think this was done before, and I don't really know how we could do that. If you don't need an echo to see that this patient is doing well, and if you look at the elements that they summarized for the parameters for readiness for surgery, this could be enough. If somebody who is having no signs of pulmonary hypertension and on low ventilatory settings, then you know your answer. You do not need an echo.
Okay, great. What is the role of repair in Down syndrome due to hyperlaxity?
Sorry, can you repeat that question?
What is the role of repair in Down syndrome patients due to hyperlaxity?
Well, I don't understand what hyperlaxity means, but I think if you have a CDH, then you should go and fix it. CDH is a CDH. If you're not sure, then get more imaging. Sometimes if you're not sure, you put a thoracoscope in and look at the diaphragm, but it's either a normal diaphragm or not normal diaphragm. It's either a CDH or eventration or just a normal diaphragm.
Okay, great, thank you. What is the percentage of volvulus before repair in CDH patients?
Percentage, very, very rare to have volvulus in CDH patients. Most of those patients do not have the classic malrotation. They're usually in a process what we call non-rotation anomaly. They usually have a wide mesentery. So the risk of volvulus is not like any other malrotation. They are in a non-rotation state, with a very low risk of volvulus. So
Okay.
it does not justify doing a LADS procedure.
We have here another question. Some right missed CDH came with liver growth above diaphragm, with IVC pass through, with atelectasis and chest infection. What we can do for this patient?
Can you repeat the question again?
Some right,
I can't see the question.
it's a long question.
Okay.
Right missed CDH, some of the patients, they come with liver growth above the diaphragm, with IVC passing through, with atelectasis and chest infection as well. So what can we do for this patient?
Well, I don't know if I fully understand the question, to be honest with you. This he's talking about a missed CDH, but the liver grew above the diaphragm, with IVC passes through, with atelectasis and chest infections. I think we have to look at the images and really discuss. You want to make sure that those patients do not have what we call hepatorenal fusion, and that's sometimes what happens is the lung and the liver is actually fused to each other, and that could be very difficult to repair because you can sacrifice the lung or the liver. So I think you have to kind of be careful about that. I think if you have you have to really understand the situation of the patient and how the symptoms are. And sometimes if you have a true hepatorenal fusion, then you may just decide not to do anything and just leave them unrepaired, because there's basically no bowel in the chest and the lungs are good and the baby is breathing well. So you may not need to do something for this. But again, this is a difficult case that needs kind of a more kind of a detailed, specified solution to this. I'm happy to, if you can want to email me and then we can discuss that.
Okay, great, thank you. The last question that we're going to take, do we need to change the size of patch with time?
Oh, no. You mean your probably question is, as the patient is growing? No, because if there's no recurrence, then you don't go there. Leave the baby alone. The patch will never grow, but the diaphragm around it will grow. So if there's no recurrence, there's no point to go back.
One more question, please. How to differentiate CDH from CPAM clinically and on X-ray? Do we need to do both AP and lateral chest X-ray in every case?
Always, always. Short answer is always. Chest X-ray, AP lateral. Do further imaging if you're not sure. Don't be worried to do less imaging. Image the baby if you're not sure. Do a dynamic X-ray, do a dynamic fluor, do an ultrasound, scan them. Sometimes you're not even sure. You may put a thoracoscope to actually diagnose. So don't be worried to do more testing. You do not want to have any surprises in the OR.
Okay, million thanks to you, Dr. Abdullah, for your time and for these great presentations that you gave us today. We are really honored to have you as a presenter. Thank you again. Sorry if I didn't ask your all questions. If you have questions that were not answered, kindly send it on Twitter account. Thank you all. Thank you again, Dr. Abdullah.
Thank you for having me.